Formal disease presentation for shocks. My name is Helen Alnabwani. Shocks is a life-threatening condition that occurs when the body is not getting enough blood flow that requires immediate medical attention and treatment. There are different types of shocks depending on the cause. Hypovolemic shock, including hemorrhagic shock caused by severe blood loss, or non-hemorrhagic shock caused by severe dehydration. Cardiogenic shock, this shock caused by reduced contractility, valve abnormality, or arrhythmias. The third type is obstructive, and the fourth type is distributive shock, including septic. Septic shock is a life-threatening organ dysfunction caused by an infection. Anaphylactic shock is a life-threatening allergic reaction to antigen, and neurogenic shock caused by spinal cord injury. Shock's clinical presentation, including confusion, increased liver function tests, coagulopathy, gastroparalysis, myocardial infarction, arrhythmias, increased serum creatinine and BUN, decreases urine output, and cold and clammy skin. There are different treatment strategies depending on the type of shocks. For hemorrhagic hypovolemic shock, we need to provide the patient with blood transfusion to replace oxygen carrying capacity and clotting factors. Also, it's very important to note that fluid administration shouldn't be provided because it worsens bleeding due to dilational effect. Non-hemorrhagic hypovolemic shock, we need to provide the patient with fluid resuscitation, including crystalloids or colloids, to increase intravascular volume and venous return. For cardiogenic shock, the treatment including perfusion, either PCI or CAPG, cabbage, inotropes, vasopressors, or mechanical circulatory support. For obstruction shock, we need to know what causes the obstruction shock and remove the obstruction. The treatment for septic distributive shock, we follow surviving sepsis campaign within 1 hour bundle. This includes 5 main steps. The first one is measure lactate level and remeasure it if initial lactate is more than 2 millimole per liter. The second step, we obtain blood and other relevant cultures. Then we administer broad spectrum antibiotics. The fourth step, we rapidly administer 30 ml per kilogram crystalloids for hypotension or lactate more than 4 millimole per liter. Then we start vasopressors if hypotensive during or after fluid resuscitation. This is to maintain main arterial pressure more than 65 millimeter of mercury. And if not responding to fluid resuscitation and increasing vasopressors, at this point we need to use corticosteroids. Vasopressors, they are used in vasodilator shock not responding to fluid resuscitation, and they are less often used in cardiogenic or hypovolemic shocks. There are 2 types of vasopressors, catecholamine and non-catecholamine. Catecholamine including norepinephrine, epinephrine, phenylephrine, and dopamine. Non-catecholamine including vasopressin and angiotensin II. The adverse effects that we might expect from using vasopressors are extravasation, organ and digital ischemia, tachyarrhythmias, and metabolic changes, including hyperglycemia or hyperlactemia. And now for fluid resuscitation, we might wonder which one to use, crystalloids or colloids. Based on safety trial, there's no significant clinical differences between crystalloids, which is 0.9% NaCl, also called lactated ginger, and between colloids, which is 5 or 25% albumin. And since there's no significant clinical differences between them, they suggest to use the cheaper one, which is the crystalloids, 0.9% NaCl, or also called the lactated gingers. Monitoring parameters for shocks including efficacy monitoring and safety monitoring. Efficacy monitoring includes mean arterial pressure, heart rate, and infusion rates. For safety monitoring, including peripheral vasoconstriction, electrodiagram, ECG, and telemetry, and adverse events associated with each vasopressor.